SBIRT, Screening, Brief Intervention, and Referral to Treatment, is an evidence-based approach to identifying patients who use alcohol and other drugs at risky levels with the goal of reducing and preventing related health consequences, disease, accidents, and injuries. In this presentation, we will specifically be focusing on alcohol use disorder. The American Academy of Pediatrics Committee on Substance Abuse policy statement points out that, quote, as a group, adolescents are at the highest risk of experiencing substance use-related acute and chronic health consequences, so they are also the group likely to derive the most benefit from universal SBIRT, end quote. Alcohol abuse is the most common and best documented form of abuse. However, the general approach applies to all forms of substance abuse. In order to effectively implement SBIRT into an adolescent practice, it's important to consider these aspects of substance abuse screening and treatment. When engaging with patients with substance use disorders, recognizing the attitudes you bring to the provider-patient interaction is an important first step. Next, understanding abuse as a medical problem allows you to approach it as you do other diseases. Understanding the frequency of substance use disorders among adolescents justifies screening. And finally, a subsequent video will discuss a specific approach for assessing and treating the range of alcohol use disorder. This approach focuses on motivational interviewing and is generalizable to all forms of substance abuse, as well as other medical problems such as smoking cessation and medication compliance. Substance use disorders in adolescents as well as adults are often seen as a social failing rather than a medical disease. Prevalent attitudes about adolescent substance users is that they may have low self-esteem, poor peer choices, impulsive behaviors, or inadequate parenting. Although these may contribute to an adolescent's substance abuse, the best model for understanding adolescent substance abuse, including alcohol use disorder, is to see it as a medical problem. This model is supported by the fact that there is an established biologic mechanism, there are recognizable signs and symptoms, there are identifiable risk factors and predictable outcomes, and most importantly, alcohol use disorder responds to treatment. The CNS reward system is essential for all learning and memory and is influenced by multiple and varied life experiences, including drugs and alcohol. The experience you get when using a drug plays a large part in how much you use, control of use, and potential addiction. That is, this subjective experience can result in either greater feelings of reward or lesser feelings of aversion, which can then lead to the risk of abuse. Alcohol is thought to work via the inhibitory neurotransmitter GABA and stimulates the nucleus accumbens, which results in a decrease in aversive symptoms like anxiety. Drugs like cocaine produce feelings of greater reward by upregulating the pathways. Alcohol use disorder, like other medical problems, includes recognizable signs and symptoms: tolerance, dependency, withdrawal, and continued use despite negative consequences. Tolerance is the capacity of the body to become less responsive to a drug. Dependency means needing a drug to function normally, and withdrawal refers to the fact that abruptly stopping the drug leads to symptoms such as feelings of dysphoria and anxiety, and physical signs such as sweating, tremor, and increased heart rate. All of these lead to continued use of the drug despite negative physical and social consequences. Alcohol use disorder, like other medical problems, has identifiable risk factors such as adverse childhood experiences, ACEs, and a positive family history. The prevalence of ACEs is shown in this table from the CDC study done on 17,337 patients in the Kaiser Permanente system. In this study, 22% of the population had 3 or more childhood experiences in the categories of abuse, neglect, or household dysfunction. With 3 or more ACEs, the prevalence of moderate to severe alcohol use disorder was 27%, as compared to a prevalence of 8.5% in the general population. Thus, ACEs are a useful predictor of alcohol use disorder. As mentioned earlier in this presentation, There are many similarities between alcohol use disorder and other forms of substance abuse, including marijuana, cocaine, and opioid dependency. For instance, compared with people with 0 ACEs, people with 5 or more ACEs were 7 to 10-fold more likely to report illicit drug use problems, addiction to illicit drugs, and parenteral drug use. The ACE score has a strong graded relationship to the risk of drug initiation from early adolescence into adulthood and to problems with drug use, drug addiction, and parenteral use. Research has established that adolescence is a period of neurodevelopmental vulnerability for developing addictions. Age at first use is inversely correlated with lifetime incidence of developing a substance use disorder. Monitoring the Future National Survey 2013 overview reported that in a study of 41,700 8th, 10th, and 12th graders, 28% had consumed alcohol by the end of 8th grade and 68% had consumed alcohol by the end of 12th grade. Additionally, 52% of 12th graders reported being drunk at least once in their lives. Approximately 17% had used marijuana by the end of 8th grade and 46% by the end of 12th grade. 22% of those surveyed reported using prescription drugs inappropriately by the end of 12th grade. SBIRT allows identification of adolescents at risk for substance abuse. Multiple screening tools are available for use in primary care offices, some as brief as a single question during an interview. The CRAFT is a screening tool designed to be used for children between ages 14 and 21. It is recommended by the American Academy of Pediatrics Committee on Substance Abuse for yearly screening of adolescents. The CRAFT begins with 3 opening questions that are answered by all adolescents. In summary, recognizing common attitudes about alcohol use disorder and acknowledging that it is a frequent medical problem supports universal screening in primary care offices. As mentioned, the next video will discuss motivational interviewing. This approach is generalizable to all forms of substance abuse and other adolescent medical problems. The subsequent video does not deal with another important aspect of a model office plan, which is the issue of confidentiality. The American Academy of Pediatrics suggests establishing a written office policy on adolescent confidentiality as an important way to improve access to confidential care for adolescents with problems like substance abuse. Check your understanding by taking the following quiz. Listen to each question, pause the video, and select your answer. Then listen to see if you are correct. Evidence supporting substance abuse as a medical problem includes which of the following? A, there is a biological mechanism. B, there are recognizable signs and symptoms. C, risk factors are identifiable and there are predictable outcomes. D, it responds to treatment. E, all of the above. The correct answer is E. ACEs, adverse childhood experiences, include A, emotional neglect, B, parental separation or divorce, C, physical abuse, D, all of the above. The correct answer is D. Monitoring the Future reported that blank % of adolescents surveyed had used marijuana by the end of 12th grade. A, 2%, B, 46%, C, 98%. The correct answer is B. Go on to adolescent SBIRT implementation.